Good afternoon, everyone. Welcome you all to today's Indians session on brain stimulation. Last month, we had a session on WISER neuromodulations. It's about its introduction and what is done there. And today we have with us Dr. Janardhanan CN, who is Associate Professor of Psychiatry in NIMHANS, who would be continuing the last month's discussion on WISER neuromodulation.
Hello, good afternoon. So I understand that Dr. Venkat had a session with all of you last month regarding TDCS and its transcranial electrical stimulation and its basic principles. So today I will be discussing a little bit on the applications of TDCS and its allied methods in psychiatry. So when I say transcranial electrical stimulation, the kind of the stimulatory methods that come under this would be TDCS and its advancement called high definition TDCS. Then there is transcranial alternating current stimulation, transcranial random noise stimulation, etc. But then at this point of time, the research is much more in this particular field of TDCS. So I'll be focusing on TDCS and its applications primarily. I don't have conflicts of interest to or any specific disclosures. You know what TDCS is? It's a non-invasive brain stimulation technique which employs direct current using bioconducting electrodes, and it results in polarity-specific neuromodulation in the underlying brain regions. That is the hypothesis. And the principle is pretty straightforward in terms of how to apply this particular brain stimulation technique. There is a battery source, which it's a very simplistic representation there, but at least there's a battery source which gives a constant direct current, and it is delivered through an anode and a cathode. So anode is a place where you have the positive stimulation, and cathode is a place which is considered to have an inhibitory stimulation. So there are two regions on the scalp where you target the underlying brain regions using the anode or cathode respectively. Now the central dogma, as I mentioned, is about how you use the anode and cathode, and the anodal stimulation is thought to result in shifting of the membrane potentials towards depolarization, whereas the cathodal stimulation is something which results in the change in resting membrane potentials towards hyperpolarization. If you were to compare and contrast it with the other neuromodulation strategies such as the transcranial magnetic stimulation or say the classical one, which is electroconvulsive therapy, the primary aim of giving such a stimulation in those contexts is to produce an action potential. Whereas in the context of TDCS, the change that is expected is a shift in the resting membrane potential, and it generally doesn't produce action potential. So it might have implications in the way we understand TDCS and its effects as well as the side effects, because unless there is a depolarization, unless there is action potential, and action potential, there is the possibility of seizures is quite minimal. So like as you can see in this particular graph, anodal TDCS would result in the resting membrane potential shifting towards depolarization, and vice versa with cathodal stimulation. Now, what can happen with repeated sessions of TDCS is that there could be enhancement in the cortical excitability, which means that the firing rate of the neurons would increase with repeated stimulation using TDCS. And when there is a repeated sessions, what can happen ultimately would be changes in plasticity. So how do we know that such a thing happens? So we need to look at evidence at each level. So the first question can be that anode or cathode respectively, how does it actually result in depolarization, hyperpolarization? So in that context, does the current actually reach the brain? That would be the first question. Does resting membrane potential really change? Does cortical excitability or the rate of neuronal firing change? And finally, does it result in neuronal plasticity changes? So there are various questions at different levels that are possible to conceive. And there are evidences from in vitro studies, animal studies, computational modeling, neurophysiological studies in humans, etc., which addresses various questions. For instance, the question of does the current actually reach the brain can be understood from some of the animal models, as well as the computational modeling studies, which are otherwise known as finite element modeling studies, and neurophysiological studies in human beings. And does the resting membrane potential really change is answered by the in vitro studies, and things such as does cortical excitability or the rate of the neuronal firing change can be understood from in vitro studies, animal studies, etc. And finally, there are enough number of studies to substantiate the fact that synaptic plasticity indeed changes with repeated transcranial electrical stimulation. I'll just touch upon what is called computational modeling before I go into the evidence for each psychiatric condition. FEM is one method by which one can understand whether the electrical activity reaches the desired brain region. And because in this particular model, you feed in the properties, the thermodynamic and electrical properties of various layers of or various barriers that the current has to pass through in order to reach the target brain region, which includes the skin and the hair, subcutaneous fat, skull bones, dura, CSF, etc. So, how is it done? It's done using a model which is derived out of a T1 weighted MR image of the respective patient or subject. And then there are algorithms which are applied to model the current densities in each tissue with any kind of specific TDCS electrode or montage. What has been known is that, like I mentioned previously, anodal stimulation, does it actually change electrical potential, and what does it do on repeated stimulation, and what does cathodal stimulation do? So there are studies which has looked at the effect of TDCS on motor evoke potential. So motor evoke potentials are measured using TMS. So if the motor evoke potential changes in a particular direction, it means that your TDCS stimulation is happening with a specificity of either anode or cathode. Say, for instance, there was a study which actually looked at the specific effect of anodal stimulation vis-a-vis cathodal stimulation. What was found is that anodal stimulation, when it was given to subjects, and then when you measure the motor evoke potential, the motor evoke potential tends to be higher, whereas in cathodal stimulation it comes lower. And as repeat number of stimulations are more, as the number of TDCS sessions are more, the MEP changes are much more pronounced and substantial. I'm not sure if this TDCS equipment in particular has been discussed in the previous session by Dr. Venkat. So I've tried to put everything into one picture from our lab. So there is a device which delivers a constant current, which is direct current of a particular intensity and amplitude. It is delivered using a particular device. I've given a sample device which we commonly use. And then there are electrodes, which are bioconducting electrodes, and the electrodes are inserted into sponge covers, and then they are kept on the scalp. To keep it snugly fit on the scalp, there are straps which are used, and on the electrodes, for improving the conductance, isotonic saline or hair gel may be used. And there is a measuring tape which you can see in order to understand the 1020 EEG location of where are you supposed to keep the anode or cathode based upon the disorder that you're going to study or the disorder that you're going to treat. The current waveform of TDCS is depicted here. So when you look at it, I'm just trying to compare and contrast it with the ECT waveform. As you can see, the brief pulse ECT waveform on the right side, and on the left hand side you can see the TDCS waveform, which is either anodal or cathode. Anodal is represented by the red line and cathodal by the blue line. And what you can see is that when the TDCS starts, it increases the current in a gradual way, which is called ramp up of current. Then it reaches a plateau phase, which is based upon the protocol. For instance, in schizophrenia protocols, it might be 20 minutes of stimulation, or in depression protocols, it could be 30 minutes of stimulation, etc. Or if you're looking at an experimental situation, it could simply be 5 or 10 minutes. So whatever it is, the duration of the plateau is what is generally decided as per the protocol. And there is a ramp down phase wherein the current is gradually brought down to the baseline. So this is the waveform of the DC, which is delivered using TDCS. And the electrode placement of the conventional TDCS, which I showed you in the previous picture, is what I've tried to depict here. For depression, generally, these are representative examples of various disorders. So in depression, the anodal electrode is placed over the left dorsolateral prefrontal cortex, whereas the cathodal is placed over either right supraorbital area, and there are studies which have looked at the right DLPFC also. In schizophrenia, on the extreme right, you can see the cathode is placed over temporoparietal junction and anode over DLPFC. And there is some montage which is used in some studies in OCD from our center as well. So this particular location is specified by using 1020 EEG electrode system. And this can be plotted using measuring tape, and one can mark it on the scalp and keep the electrodes. Now, this is a standard way of using conventional TDCS, whereas there are some advances of TDCS which is called high definition TDCS, slightly costlier equipments. At this point of time, they are much more commonly used in research settings rather than on routine clinical settings. But this particular method uses very small electrodes. The size of electrodes is 1 centimeter, whereas the electrode which I showed you previously, the ones which are in black in this particular diagram, in this particular picture, it is 35 centimeters square or 25 centimeters square, whereas here the electrode size is only 1 centimeter diameter, which is extremely small, with an intention to deliver focused current on a particular brain region. And as you can see in the scalp cap which is used there on the right side, there is a central electrode. Surrounding that, there are 4 other sockets. The 4 other sockets would assume the opposite polarity. For instance, if you are keeping the central electrode as anode, all the other 4 electrodes would take cathodal positions, which means that suppose you are going to give 2 milliamperes in the central one, all others would equally distribute the current as minus 0.5 milliampere each to complete the cathode surrounding. The whole idea is to have a focused electrical stimulation of the underlying target region. So this is the basic principle of high definition TDCS, and this particular device also comes with methods of neuronavigation, etc., which is basically using the subject's own MRI to identify the specific brain location, and in addition to the EEG localization that we spoke about just now. So these are in order for you to understand, there are 2 different kinds of TDCS setups. One is a conventional one, the other one is a high definition TDCS. For conventional one, it is generally an anode and a cathode. There are 2 electrodes which assumes 2 regions of the brain, which means that generally we intend to activate one particular brain region and inhibit the activity of the other region in order to complete a circuit. So it has to be placed and planned in accordance to the hypothesis that we are working on. Whereas HDTDCS is like it's primarily for one particular localization, and the central electrode would be surrounded by the electrodes of opposite polarity. The advantage of HDTDCS would be a greater focal stimulation, and probably a better neuroplasticity effect is also something which has been reported with HDTDCS. But generally, for clinical purposes at this point of time, the TDCS method that is used is conventional TDCS itself. Okay, I was trying to look at the research trends in TDCS, and this was made by a colleague of mine. So what he did was he looked at the number of TDCS entries in Google Scholar over the past 2 decades. So what you can see is that from 2000 onwards, there's a steady increase in the number of publications that has come up using TDCS, and it probably has reached a peak in 2017 till now. And when you try and compare it with the modalities such as RTMS and ECT, you can actually see that the number of TDCS related studies is actually steadily peaking from 2010 onwards, meaning to say that there's a resurgence in interest in TDCS. Not that this is something which is discovered recently. This is something which has been spoken about for many years. In fact, I'm sure the historical perspectives of TDCS was discussed in the previous session. But then there was, it probably had a latency phase or lucid phase for a while, and then now from 2010 onwards, there is a steady increase in the number of publications and articles related to this particular brain stimulation method. Again, this is an interesting word cloud which was generated to look at what are the different conditions for which TDCS is being evaluated. As you can look at it, pain syndromes probably tops the list, and the one which is the most bold in color is what has been mentioned here. So most number of clinical trials, as you can see, is for neuro-rehabilitation and pain syndromes, fibromyalgia, etc. But there are evolving studies in the context of the major illnesses in psychiatry, such as depression. And recently, in the past 5 or 6 years, there has been a renewal. There's an interest in schizophrenia, and our group has also been working on conditions like OCD, etc. So roughly, these are the indications of TDCS. On neurology side, you can see the most studied one is post-stroke rehabilitation, which looks at the interface of motor deficits, cognitive deficits, speech deficits, etc. In Parkinson's disease, headaches, fibromyalgia, and these are the other indications in neurology. Whereas in psychiatry, you can see depression probably tops the list. I've kept schizophrenia and other things primarily because of the work which is coming from our center and some other centers in our country. World over, now there is, at least in the past 5 or 6 years, there are a good number of studies in schizophrenia looking at various symptom dimensions of schizophrenia. OCD is an interest that we have and we have published, and there are some studies in substance use and craving management, and a lot of studies looking at the investigative benefits of TDCS and understanding the etiology and pathogenesis of various psychiatric disorders. I'll start with schizophrenia because I'll have some slides looking at the kind of evidence that we were able to get from the studies that were conducted in our center. This was one study which probably sparked a lot of interest in the use of TDCS in auditory verbal hallucinations. This was a study which is published in American Journal of Psychiatry in 2012. And what the authors did in the study was to look at the effect of TDCS using a one particular specific electrode placement or montage placement in using cathode on temporoparietal junction and anode on the left dorsolateral prefrontal cortex, because we know that the hallucinations probably have a seat in the posterior-most part of the temporal lobe. So temporoparietal junction has been considered to be an important region which is involved in the pathogenesis of auditory verbal hallucination. So the cathode or the inhibitory electrode was kept on temporoparietal junction on the left side. Whereas we also know that there is hypofrontality in schizophrenia, so it might make sense to improve the activity of dorsolateral prefrontal cortex. So in this case, the authors kept anode in the left DLPFC to complete the circuit, and they were trying to examine if the primary outcome of auditory verbal hallucinations get reduced by TDCS when it is delivered in this particular manner. And how did they do it? They tried comparing actual stimulation versus sham stimulation. When I say sham stimulation, the second group doesn't get the active continuous electrical current, but it might happen in small spurts, which is unlikely to produce any beneficial effect. Now, this was given for 5 days, and each day for 20 minutes, spaced by 3 hours. That was a regimen that this particular study has used. And they looked at the effect of TDCS after 5 days. They followed up these subjects at the end of 1 month as well as at the end of 3 months. As you can see there, the sham stimulation versus active stimulation, you can see there's a substantial reduction in the score of auditory hallucination rating scale. AHRS is a scale specifically used to understand the severity of auditory verbal hallucinations. And they found there's a significant benefit with true TDCS compared to sham TDCS. And this benefit seems to be persisting at the end of 1 month, as well as at the end of 3 months of follow-up. That was quite encouraging. And a substantial number of patients had improvement in negative symptoms as well as positive dimensions of PANSS. Now, taking from this, there was an RCT which we completed. It was primarily done by a colleague of ours by the name Anushri. So what we did was we examined treatment refractory schizophrenia patients who had persistent auditory verbal hallucinations. 25 of these subjects were randomized to receive this particular protocol, true TDCS for 12 patients and sham TDCS for 13 patients. Randomization was central, and the person who received TDCS, the person who delivers TDCS, as well as the person who rates auditory verbal hallucinations, all at 3 levels, there was blinding that was ensured. And the reassessment was done at the end of 5 days to see if there is a change in hallucination score. And what was the protocol was that at the end of 5 days, in case the improvement was satisfactory, that is more than 30% reduction in auditory verbal hallucinations, the study was considered to be complete. If it was not achieving a 30% reduction in auditory verbal hallucinations, the subjects were given an option to participate in an open label extension part of the study in the next week, which means that in the open label extension phase, the subject would know that they are going to indeed receive a true TDCS. So they'll be given a chance to receive true TDCS in the second week, and they would be assessed again at the end of second week. As you can see in the graph on the top left side, true TDCS had a significant benefit compared to sham TDCS in terms of improvement in auditory verbal hallucination score. And people who had received sham in the first week and then crossed over to true TDCS at the end of second week also had a significant reduction when they received true TDCS, meaning to say there is a significant benefit of the stimulation type. So true stimulation seems to be quite beneficial. And this was quite encouraging. And we also noted in another study that this improvement in auditory verbal hallucinations also correlated with improvement in insight. So by the end of this particular treatment, many patients were able to appreciate the fact that, this probably isn't really true. This may be imaginary. And hence, this might have a lot of repercussions in terms of getting people into treatment and getting people adherent to treatment in the due course. Now comes the next part of next kind of symptom dimension in schizophrenia, which is very hardy otherwise, because medications are not really useful in a big way to treat negative symptoms of schizophrenia, as we all know. And so there are a lot of methods of treatment which people are trying to devise over across the world to target negative symptoms. So there have been some studies which have looked at the use of anodal DLPFC stimulation on the left side for improvement of negative symptoms in schizophrenia. So SAM score is for negative symptom score was examined as an outcome variable in some of these studies. And what people have found is that true TDCS had a significant benefit over sham TDCS in negative symptoms as well. But then most of the studies talk about greater number of sessions for the treatment of negative symptoms than the number of studies that you would use to treat auditory verbal hallucinations. And this is again the example of the diagram of high definition TDCS, which I showed you some time back. So using this particular stimulation, we also try to examine if HD TDCS might be beneficial in schizophrenia. Very similar to conventional TDCS, we found in an open label setting, we found that auditory hallucination rating scale score improved with high definition TDCS as well. I'm just trying to summarize the various symptom dimensions of schizophrenia and the meta-analysis of the randomized controlled trials. What is very clear is that auditory hallucinations has a significant reduction, and it favors the use of TDCS compared to sham in this particular forest plot that you can see there with a reasonably good effect size. Similarly, the negative symptoms as well, there is a significant improvement. And overall, when you look at the composite scale in PANASYS, there is an improvement in overall symptoms as well. So this is a meta-analysis which was published a couple of years back on various dimensions of schizophrenia. Okay, I think I can skip this because we have highlighted the negative symptom. This is again a meta-analysis which proves that negative symptoms also might improve significantly with TDCS. Now, the other concern in schizophrenia is cognitive deficits, because we know that cognitive deficits are, generally they persist despite medications, and they can be a major concern for people who remit also. So in that context, it might be useful to look at whether some of the neuromodulation strategies might be useful in handling the negative symptoms of schizophrenia. There are some studies which I'm highlighting here, which looks at dorsolateral prefrontal cortical stimulation, whether that results in improvement in cognitive deficits. And if you may recollect the cognitive deficits of schizophrenia, and there are some cognitive deficits which actually stand apart, which means that it stands out. So one of them is working memory. The other things are verbal fluency and so on. A lot of frontal deficits are the ones which actually stand at least 2 standard deviations different in comparison to the healthy volunteers. So there are studies which looked at the use of online TDCS. While a person is undergoing TDCS, the person does a working memory task, and you compare it with sham stimulation. While the person is undergoing TDCS, a sham stimulation, or it could be a true stimulation. Then they look at whether working memory improves or executive functions improve, etc. So what has been found is that there could be initial evidence which suggests improvement in some of these cognitive deficits by the use of TDCS. And the limited evidence suggests that higher current densities and longer stimulation durations might be more effective in modulating some of these cognitive deficits like working memory. Okay, this is in nutshell regarding schizophrenia. So we looked at whether schizophrenia symptoms such as auditory hallucinations, negative symptoms, or generally the total symptoms in general, cognitive deficits. So these are the important symptoms of schizophrenia which one would like to target specifically. And there are individual studies, but then the best evidence actually goes at this point of time for reduction in auditory verbal hallucinations. So this may be considered as an interesting evolving strategy to look at handling auditory verbal hallucinations in people who have refractory symptoms. Now, coming to depression, the reason why I kept depression second is not because of the lack of evidence in depression. In fact, depression has the best evidence as far as TDCS is concerned. Depression, there are a couple of different montages that has been suggested. One of them is to use the left DLPFC anodal TDCS, whereas cathode might be kept somewhere away. Whereas there are some other studies which have looked at bilateral dorsolateral prefrontal cortical stimulation, whereas you keep the left DLPFC, keep the anode on the left DLPFC and cathode over the right DLPFC, and then complete the circuit and then use it. The general protocol is at least 10 sessions. Some of the newer protocols use more than 10 sessions twice daily. And some of the initial open label studies actually show important improvement. I would like to specifically highlight this particular study because of the fact that this is one study which has used a large number of participants. And there's a name also for this particular study called the SELECT trial. It's sertraline against TDCS in depression trial. This was quite an encouraging kind of a result which the study gave, with almost 120 participants who were medication free at the time of enrollment into this particular study. They used a 6-week treatment of 2 milliamperes anodal left and cathodal right prefrontal TDCS and compared that with sertraline treatment 50 milligrams per day. And what was found, it is a non-inferiority design, and what was found is that analysis of TDCS only versus sertraline only presented comparable efficacy, which means that TDCS was almost similar to the efficacy of sertraline, whereas it was not as good as it was definitely much better than placebo or sham TDCS. This is a meta-analysis of some of the studies that has been done till date in the context of depression. Not so many in this particular meta-analysis. There has been few other studies which have been added much later. And at least based on this initial meta-analysis, as you can see, there's an overall effect in favor of TDCS in the context of depression. One natural question that can happen is that, like the way we talk about antidepressant medications, can TDCS or electrical stimulation of the brain result in the polarity getting shifted to the other end? Can manic switch happen because of TDCS? In fact, manic switch, treatment emergent manic symptoms are pretty limited, or the number of reports of treatment emergent manic switch is very less. So there is one meta-analysis which has looked at the treatment emergent switch as well. So what they have found is that the participants with treatment emergent manic symptoms was quite less, as in people who received true TDCS versus sham TDCS. It was 8 out of 226 and 1 out of 190. So ultimately, this particular difference was not really statistically significant, meaning to say that stimulation did not actually bring about significantly more number of manic episodes. So this is a Canadian network for mood and anxiety treatments, which is CanMAT guidelines for management of adults with major depression. So the section 4 talks about neurostimulation treatments. I'm just highlighting the last part of it, the conclusions. What it says is that there is increasing evidence for efficacy, tolerability, and safety of neurostimulation treatments. They consider RTMS as a first-line recommendation for patients with MDD who failed at least one antidepressant. ECT definitely remains an option, while TDCS and other options are still considered third-line recommendations because the evidence is just upcoming. And there are some other investigational treatments which they consider. So meaning to say that TDCS is now slowly, sneaking its way into the treatment guidelines as well. Coming to OCD, I have some special interest in this particular context because I work primarily with the OCD patients. So we have been working with TDCS to improve some of the concerns in OCD, especially the treatment refractoriness in OCD. Can that be handled with TDCS is a question that we are working on. The reason why we're working on this is because of the well-known circuitry model of OCD, which probably helps us understand whether where to put the electrodes. Because if you have a circuitry-based understanding, so it might be you can understand that if you stimulate certain brain regions, you might hypothesize that some changes can happen in a desired direction. So what is known is that there are certain specific circuits which are abnormal in OCD, and overall these circuits are called cortico-striato-thalamocortical circuits. And these circuits are parallel, probably partially non-overlapping kind of circuits, which run from different parts of the cortex through basal ganglia to the thalamus and finally back to the cortical regions. And the regions that are involved are the orbitofrontal cortex, then you have the ventrolateral ventromedial prefrontal cortex, then you have pre-supplementary and supplementary motor area in the cortical regions. In the subcortical regions, you have basal ganglia with specific regions which involve caudate, putamen, nucleus accumbens. Then you have limbic system, which is primarily the amygdala, and then you have the thalamus, various nuclei of thalamus. So based upon this, there are some circuits which are quite well known. One is the ventral cognitive circuit, which is involved in the response inhibition, the dorsal cognitive circuit, which is involved in working memory, planning, emotion regulation, and so on. Then you have a reward circuit, which passes through the nucleus accumbens, and basically it depends. It talks about the stimulus outcome and motivational behavior in patients. Then we have the frontolimbic circuit, which is essential for the fear extinction, a circuit which is really important in the context of cognitive behavioral therapy, for instance. And then one circuit which is being spoken about very frequently nowadays is the sensory motor circuit, which starts from supplementary motor area and somewhat involves a pre-supplementary motor area as well. And this circuit is important in the context of stimulus response behavior or habitual behavior. The more you start doing certain things in a particular way, the brain starts wiring it in a particular way that you don't really look at the consequence of what you're doing. But the moment I can give you an example. The moment I start, my hands are dirty, I have to wash. There's a purpose for my washing, is to get rid of contamination. Whereas the moment I see something like a wash basin, if I have to wash, it is not so much about contamination, it's about a pattern that has already been kicked in the brain. So that's a stimulus response kind of a behavior, which is controlled by the sensory motor circuit. The reason why I'm talking about this particular circuit is because supplementary motor area is pretty much superficial and probably accessible for stimulation using TDCS. So these are some of the initial case level observations that people had, and we also had submitted case level observations of left pre-supplementary motor area anodal stimulation resulting in improvement in treatment refractory OCD patients, a couple of patients. And based on this, one of our students completed a randomized controlled study as a part of the MD thesis. So what was done in this particular study was that Shyanth recruited patients who had persistent symptoms of OCD despite adequate SSRI trials, which means that they had to be on stable medication for at least 3 months before the person were to enter into the study. And they were randomized to receive either anodal stimulation or sham stimulation. And like I mentioned, for the previous schizophrenia trial here, randomization was central. The person who was delivering TDCS, the person who was rating, as well as the person who was receiving TDCS are blind. And they are reassessed at the end of 5 days. And we look at the Y-box score. And if the Y-box score is more than 30% better, which is classically considered to be a response in most of the trials, we assume that study is completed. Whereas if the response is less than 35%, then we give a chance for them to participate in the open label extension phase, which happens on the next week. So what was found is that at the end of we had 12 and 13 participants in true and sham TDCS arms respectively. And as you can see on the left side, the Y-box total score is significantly low at the end of the TDCS in the true TDCS arm in comparison to sham TDCS arm. And probably this is the first randomized controlled study which was published in the context of OCD. And we have been using high definition TDCS now to examine this question further. So, but of course, only one RCT, it requires greater amount of replications in order to confirm this particular finding. Now, I'll just give a summary of what is the scene in the context of substance use disorders, because this is another important area wherein people have been trying to examine various facets of substance use, which are, for instance, craving is one important aspect, abstinence, and the days of abstinence that a person would be another important variable that would be of interest. So why is it important to look at, why substance use? Because of this particular hypothesis that the dopamine containing neurons, even though they are deeply located in the brainstem, by stimulating the cortical regions, there is a possibility of some of the projections to reach the ventral tegmental area as well as the nucleus accumbens because of the less number of synapses from DLPFC till nucleus accumbens. This has been proven in the animal models, primate models as well as the rat models. And the evidence at this point of time in substance use disorders, I would say that it's upcoming, and there are a lot of cohorts and centers which are working on it. But most of the studies have been proof of concept experimental studies, say, for example, looking at whether stimulation results in improvement in craving or not, etc. And some the studies generally has been open label in nature. RCTs are smaller in number. Mostly the effect that people have been looking at is on craving, and which would include nicotine craving, alcohol-related craving, methamphetamine craving, etc. The other aspect that people have been examining is the risk-taking behavior, which is basically understood through cognition. So you measure risk by understanding how good they play a cognitive task of gambling task, for instance. So there are some tasks which are specifically intended to look at impulsivity and risk-taking. So these are some of the parameters that people have been looking at to examine the effect of TDCS. So, but then this is an evolving area. Probably we might get to know more in the next few years to come. One question which people generally would have in mind is whether TDCS is useful in special populations such as children, pregnancy, elderly, etc. So I'm just trying to highlight about children. Studies are very less because it's understandable that you can't study children without a real reason, without a substantial reason to after establishing the safety of the procedure. So generally, it's well tolerated from the existing studies. The efficacy is very difficult to comment at this point of time because the studies are smaller in number. But generally, since TDCS is associated with neuroplastic changes, general recommendation is that it should be used very carefully in the developmental phases. And TDCS also has been examined in the context of mild cognitive impairment. So there are some studies which look at whether the early stages of the dementia, mild cognitive impairment, can it result in improvement in the cognitive functioning in such patients. Okay, now this is a nutshell about some of the important disorders for which TDCS has been tried. Now, what is a way forward? What have people been looking at? Because from the very description of TDCS, it might look very simplistic, anode causing stimulation and cathode causing inhibition, but that probably is a very reductionistic and simplistic approach according to the current mechanistic understanding. So what people have looked at is to improve the precision of stimulation, because when I stimulate a particular brain region by using 1020 EEG localization, you're not really sure whether the current actually goes into the respective or hypothesized brain region itself. So in that context, some of the approaches are by using something called neuronavigation, wherein you have this particular subject's MRI done recently, a T1 weighted MRI, and then you get this MRI into the software, and then you have the subject also who's sitting right there. So there are two dots that you can see there in that. One is a real-time viewing through infrared camera, whereas the green dot is the electrode location and red dot is the location of, in this particular example, it is the left pre-supplementary motor area. So because of variations in the gyri and sulci and the different anatomical changes in each person's brain, the exact localization, may not be as exact and uniform when we use 10 and 1020 EEG system. So this might ensure a highly focal stimulation of the target location. But then this is a much more cumbersome process, which is primarily used in the research settings and not so much in the clinical applications. And the second question is about whether the brain is does the brain behave similarly all the time? Because if I have a patient who has OCD, his brain at rest might be very different from the time when he sees something which is dirty in front of him, for instance, isn't it? So when you have an active brain versus resting brain, is there a difference in the stimulation when you stimulate an active brain versus stimulating a brain at rest? So the research says, yes, there is a difference. So what is that difference? If you were to the physiologically active neurons, that is the neurons that fire spontaneously at higher rates, these neurons are supposed to be more conducive for the effects of TDCS than the neurons which are at rest and sleeping. So tasks which are done using during TDCS sessions to shift, for example, if you were to use a working memory task or a task which activates a dorsal attentional network, and while this task is being done, a person receives stimulation, the effects might be a little different from stimulation that happens while the person is at rest. So this is another interesting upcoming advancement of TDCS, which probably will get a greater discussion over time. Coming to adverse effects of TDCS. Now, there are many centers which have been doing TDCS, and people have meticulously recorded how many sessions they have done. And based upon these records, people have done meta-analysis, pooling data from across various parts of the world. And there has not been, even though there are some 33,000 odd sessions which were pooled in one of the updates which is provided by Bixen and colleagues, and 1,000 subjects with repeated sessions, they have not really produced any reports of serious adverse event or irreversible sort of injury, etc. So meaning to say that the use of TDCS probably is a safer procedure. And this is from our data. We have looked at the TDCS induced adverse effects in 171 patients in this particular graph. As you can see, the blue one is subjects who received only 5 sessions. Red one indicates people who have received more than that, 6 to 10 sessions, and more than 10 sessions, what happens. So overall, there is no, what can be seen is that the kind of side effects are headache, neck pain, scalp pain, tingling, burning sensation, some kind of sleepiness. These are all very non-specific sort of side effects, but what is most commonly spoken about is the kind of skin irritation or itching sensation below the electrode localization. So that's the most commonly described side effect, which is described by most of the participants. Again, a pie chart to describe the same thing which I mentioned right now. There could be some factors which affect TDCS effects, because TDCS may not be uniformly effective in a lot of people. So what are the factors that could predict the response to TDCS? It might start from genetic factors, because since it works on the basis of neuroplasticity, there are some studies which we could examine. For instance, COMT polymorphism in schizophrenia. People with one of the polymorphism had a better response, or one of the polymorphism had a poorer response. And the other one, which I mentioned previously regarding the psychological state of participants. Say, for example, while TDCS is being done, while you present them with a drug-related cue in the context of substance use disorder, or while a task is being performed in the context of schizophrenia. So psychological state of participants might play a significant role. There is some evidence to say that nicotine smoking might have a reduced efficacy of TDCS in the context of schizophrenia. In the context of depression, there is some evidence to say greater therapeutic effect of TDCS in people having greater severity of depression. And degree of treatment resistance at the time of TDCS probably has an impact. Probably it shows, the greater degree of treatment resistance, the response might not be as great. Concomitant medications like GABAergic medications might interfere in the TDCS efficacy. And the study design, parameters of stimulation, etc., are things which are modifiable and things which can be handled by the protocol itself. So this is in a nutshell regarding how TDCS is being used in psychiatry as a field. But TDCS is one particular neuromodulation strategy which has received enormous amount of criticism. And it's important that we critique the studies that are upcoming also, because these are all studies in its infancy or initial stages. So generally, there's a common dictum that when we start any sort of treatment, be it antipsychotics, could be TMS, or it could be now it is TDCS. So anything, when the initial phases, generally the effect sizes of many of these therapies are generally found to be really big. For instance, TMS started with a bang, with the RTMS had a effect size of close to 1 in the beginning in the initial studies, and probably now it is, after so many years of experience and with more number of studies accumulating, effect sizes are now reaching moderate or mild level. Similarly with antipsychotics. In TDCS, even though the effect sizes that you saw in some of the graphs are really big, so over time as we accumulate more and more studies, we'll get the true picture. So we don't know whether there could be a secular trend in what might happen over time. One of the things that plagues TDCS research is the smaller sample size. So there is a greater need for people to look at more number of subjects, and we probably look at multi-centric studies. Now there are a lot of multi-centric, multi-country studies which are coming in TDCS. Attrition issues, because do all participants complete the 2-week course of TDCS for you to analyze at the end of it? Biasing problems, especially in the context of open label studies. If I know that I'm receiving true TDCS, there's a possibility that I might expect a significant change in my symptoms. So that's a placebo that we're talking about. So there's an observer expectancy effect, which is seen in many open label studies. And there might also be neuroethics and legal issues which people are discussing, especially in the context of healthy individuals receiving TDCS. You have TDCS even for gaming nowadays. So in general, so TDCS is now receiving a lot of fair amount of criticism. Now, having said that, it seems to be promising in its initial studies. There is a potential to induce clinically relevant behavioral changes, and it probably is in the early stages of research and treatment in psychiatry. There is a need for large studies, as I mentioned, and people also should examine the investigative applications of TDCS to understand the mechanism action of TDCS, as well as the mechanism of action as well as the mechanism of how various disorders happen in the brain. So this might be one of the interesting methods to manipulate and understand how the brain functions. So with this, I conclude. I'll be happy to receive questions.
Thank you, sir. Thank you for the presentation. There are 2 questions.
Okay.
Dr. Ravichandra Selvaraj has asked whether any specific company you suggest.
No, I mean, I wouldn't be suggesting a specific company, because there are TDCS which is being manufactured by so many other companies, but then we use some standard TDCS equipment which has some kind of a certification. What is really important is to have TDCS equipment which has safety certification available. So in that context, any equipment which has safety certification should be okay. So the equipment which I showed you in the diagram is from a company called Neurocon. That seems to be a company which has got a really good reputation, but at the same time, there are a lot of companies which produce it. Now, the second question that somebody has is about mortality related to TDCS or any specific contraindications. Generally, as of now, there has been no mortality which has been reported by TDCS. Not even morbidity rates because of TDCS adverse effects are much less, except for the side effects which I mentioned previously. Now, specific contraindications, since in electrical stimulation, generally what people recommend is to look at any implants in the brain, aneurysm clips, for example, or any sort of implants which are generally, if somebody has anything of that sort, it's better to avoid. Otherwise, there are no specific contraindications. Even seizures, which is a contraindication in some of the other brain stimulation strategies, is not considered to be a contraindication in the context of TDCS. Would Neurocon DC mobile model do? I'm not sure what is Neurocon DC mobile model. Can somebody? I mean, who's asking?
Dr. Ravichandra.
Dr. Ravichandra. Would you like to elaborate on that? I didn't understand what is DC mobile model. Are you talking about any specific models of Neurocon that you're?
Yeah.
Okay.
Yes.
Okay. Okay. I mean, I'm not sure. It must be the one which we have is not a. When you say mobile, is it something which can be used and then you can walk around? Is what you're trying to say? What is a mobile model?
Yeah, the mobile model, they suggest is one that can be used in a clinical setting.
Okay.
The other model you use is for research model, the company says.
True. So you can use it, no problem, because this basically, ultimately, it's a constant production of DC through an anode and cathode. That's a very simple principle. And Neurocon seems to be a decent, reputed company which has certification. So shouldn't be a problem otherwise.
So in Amazon, you see a lot of home-based stimulator models. And some say they are FDA approved also. Would you suggest that?
No, I mean, I wouldn't suggest that, because some of the models the examples that you see in Amazon are much more, designed towards gaming. If I can clearly, if I recollect, because there are some models which almost looks like a small ring, wherein you can keep it on the forehead here, which is primarily designed for your prefrontal cortices, a prefrontal kind of a stimulation. But then I'm not really sure about the Amazon-based models.
That's what.
I would recommend generally models which have been used in the previous studies in the context of the illness which we are studying, because that might be better off. That might be better in terms of safety.
But the cost they quote seems too prohibitive to buy in a clinical setting, sir. And the UK-based company and the German-based company, they quote somewhere around 6 lakhs.
Yeah, you're right. The Neurocon is a German company. It's slightly costly, but there are other models as well. There is another equipment called TCT which we have been using. That is definitely not as costly as these equipments. But there are other indigenous TDCS devices which are coming up in the market as well.
We heard that Nimmans is working with IIT Chennai to bring one model. So is that true, or will you be coming out with one model?
Yeah, it's not IIT, it's not Chennai IIT. We are working with DRDO, Defense in Bangalore. DRDO in Bangalore. We have been working on the prototype already, so we're hoping that we'll be able to come up with probably extremely low cost kind of devices.
Thank you so much, sir.
Yeah. So, before we end the session, we place our sincere thanks to Linux Laboratories for their support through educational grant.